This diagram reveals a massive clinical overlap. Approximately 21.2 million adults in the United States are managing a mental health condition and a substance use disorder at the exact same time. Clinical diagnosis of co-occurring disorders, or CODs, establishes that both disorders exist independently. For a diagnosis to be valid, at least one disorder of each type must be established as a primary condition, rather than a cluster of symptoms resulting from the other. Historically, clinical systems have treated mental health and addiction as competing priorities. Attempting to address these conditions as separate, isolated issues creates immediate clinical friction and severely limits the chance of a successful recovery. For decades, the medical establishment operated under a flawed hierarchy. Practitioners often viewed substance abuse as a secondary symptom of a primary mental illness. This delayed effective care, as both conditions actually require direct, primary attention. Building a sustainable path to recovery requires a framework known as integrated treatment. This is a cohesive clinical model where a single team of providers treats both the mental health condition and the substance use disorder concurrently. Because these disorders share underlying mechanisms and actively exacerbate each other, a divided treatment system leaves the biological drivers of each condition unaddressed, leading to the poor outcomes and high relapse rates seen in traditional care. Mental health issues and substance use disorders share a foundation of underlying vulnerabilities. Changes in brain composition, shared genetic risks, and early exposure to severe stress or trauma leave certain patients highly susceptible to both conditions. Once established, the conditions accelerate one another. In the self-medication pathway, individuals with untreated mental health symptoms frequently initiate alcohol or drug use as a targeted coping mechanism to manage their psychological distress. The interaction also works in reverse. Regular substance misuse alters neural chemistry, which can trigger or mimic severe psychiatric symptoms, including episodes of psychosis or acute anxiety in individuals who are already biologically vulnerable. This creates a destructive feedback loop. The untreated mental health issue drives the substance use, and the substance use intensifies the severity and chronicity of the psychiatric symptoms. Because these conditions are biologically and psychologically locked together, any clinical approach that attempts to untangle and treat them sequentially is fighting directly against the patient's own biology. The sequential model treats one disorder at a time. But treating one condition in isolation often worsens the other. Trauma therapy can trigger a substance relapse. Alternatively, the parallel model treats both simultaneously, but by completely separate providers in isolated systems. Parallel care is structurally flawed. The lack of communication between clinics leads to incomplete diagnoses, conflicting therapeutic strategies, and missed drug interactions. Most critically, parallel systems force a patient already experiencing a psychological crisis to act as their own medical coordinator, navigating the logistical friction of siloed doctors, separate appointments, and incompatible insurance billing. The integrated care model replaces this fragmented approach. It places psychiatry, therapy, and addiction counseling under one roof, managed by a single collaborative clinical team. Integrated care succeeds because it shifts the immense logistical burden of coordination off the patient, placing it firmly onto the medical providers. Co-occurring disorders are highly individualized. A standardized treatment plan based solely on a top-line diagnosis will not work for every patient. To handle patient heterogeneity, clinicians use a multidimensional assessment matrix. They measure the immediate acuity of symptoms, like acute withdrawal, against the long-term chronicity of the illnesses to determine immediate medical priorities. They must also account for co-occurring physical complications, such as malnutrition or infectious diseases that dictate pharmaceutical options. The matrix must also factor in a critical socioeconomic concept known as recovery capital. Recovery capital is the baseline of social, financial, and environmental resources available to support the patient's transition into recovery. Recovery capital measures vital stability factors, like secure and safe housing, steady and reliable employment, and supportive social networks. A patient with severe clinical symptoms but high recovery capital requires a vastly different treatment plan than a patient with similar clinical severity but zero housing or financial support. Gathering all this critical data requires universal screening. Every patient entering a substance use or mental health setting must be evaluated for both conditions. A true integrated architecture treats the whole person by mapping their clinical severity directly against their real-world survival resources. Successful integration depends on the active modification of traditional therapeutic interventions. Co-location of medical specialists is insufficient if the clinical protocols themselves remain siloed. Mental health protocols must be adapted to account for the limitations imposed by active substance use, and addiction counseling must be paced to accommodate the cognitive deficits associated with serious mental illnesses. Consider the clinical case study of Susan, a 34-year-old patient diagnosed with both bipolar disorder and an alcohol use disorder, or AUD. Susan's dual diagnosis creates specific clinical friction. Her conditions cause significant memory deficits, resulting in her frequently forgetting the discussions, coping strategies, and decisions established in recent therapy sessions. Instead of pushing through a standard curriculum, the integrated clinician alters the session structure itself. They build heavy repetition directly into the timeline, starting every appointment with a comprehensive review of the last, and leaving dedicated time at the end to summarize again. The clinician also implements external reminder systems and alarms, ensuring the therapy takes hold despite the patient's cognitive impairments. Integrated care succeeds by tailoring the skill acquisition process to the specific cognitive and functional abilities of the individual, rather than forcing a complex patient into a rigid, standardized protocol. Despite integrated treatment standing as the clinical gold standard, widespread adoption has stalled over the past decade. Looking at outpatient clinics across the United States, current data shows that only about half of mental health and substance use facilities actually operate specific, dedicated programs for co-occurring disorders. Widespread adoption faces deep-seated structural and systemic friction, which persists despite strong clinical evidence and provider support for the model. Providers face massive bureaucratic hurdles. State regulatory boards, licensing requirements, and reimbursement processes are almost entirely segregated between mental health and substance use disciplines. Fee-for-service insurance models, where providers are paid exclusively for distinct, isolated procedures, actively punish integrated care by refusing to reimburse vital communication and coordination time required between doctors. There is also a severe workforce deficit. The industry lacks the formal, on-the-job training infrastructure needed to equip behavioral health professionals with the cross-disciplinary skills required to treat complex CODs. Failing to treat co-occurring disorders effectively at scale is a failure of healthcare policy and financing, not a failure of medical science. Overcoming these barriers requires systemic policy shifts. State regulations must be streamlined, and technical assistance funding must be expanded to support cross-training programs. At the micro-environmental level, the patient's family and the entire support system must be actively utilized within the integrated care matrix. Families are brought directly into the therapeutic process. Clinicians train support networks to implement specific communication strategies, establish healthy boundaries, and work towards shared recovery goals. Treating co-occurring disorders means addressing a unified architecture. You cannot choose which disease to fight first when both actively attack the foundation. Whether you're a clinician building a modern practice or a family advocating for a loved one, demanding a simultaneous, integrated treatment system is the proven path to sustainable healing.